evaluation, laboratory evaluation, and additional monitoring. For the clinical evaluation, the examination of the body and review of the patient lab test result are used to determine the presence or absence of a medical condition. Next, please. For the laboratory evaluation, complete blood count with differential. In CBC, leukopenia and thrombocytopenia are noted. Acute phase reactants such as ESR and CRP. Urinalysis with examination of urinary sediment. Spot urine protein to creatinine ratio. Serum creatinine and estimated glomerular filtration rate, which has an elevation in serum creatinine, can also affect lupus nephritis. Anti-double-stranded DNA and complement levels. Additional investigations such as ECG, lung function tests, radiography, CT scans, and renal or other organ skin biopsies may be required to further analyze the abnormalities discovered on the clinical evaluation. Treatment is based upon clinical manifestations, patient preferences, disease activity and severity, and comorbidities. Goal of the treatment: to ensure long-term survival, to achieve the lowest possible disease activity, to limit drug toxicity, to prevent organ damage, to improve quality of life, and to educate patients about their role in disease management. For the non-pharmacologic and preventative interventions, we have the sun protection. Exposure to ultraviolet light may exacerbate or induce systemic manifestations of SLE. Patients should avoid exposure to direct reflected sunlight and other sources of UV light. Patients can also use sunscreen that can block both UVA and UVB and have a sun protection factor of more than 55. For the diet and nutrition, balanced diet consisting of carbohydrates, proteins, and fats. Additional considerations also include increased caloric intake with patients that have high active inflammatory disease, glucocorticoids to result in weight gain, and multivitamins for patient who does not obtain adequate weight. For the exercise, inactivity caused by acute sickness results in a rapid loss of mass, bone demineralization, and stamina loss, leading in weariness. This is usually manageable by isometric and graded exercise. For smoking cessation, cigarette smoking should be discouraged among patients since it has been linked to more active diseases. In addition, there is additional evidence that smoking reduces the efficacy of one of the SLE drugs. For the immunization, it is recommended that patients obtain the appropriate vaccines before the beginning of immunosuppressive medications. Treating comorbid conditions, accelerated atherosclerosis, pulmonary hypertension, and the antiphospholipid syndrome, as well as osteopenia or osteoporosis, are all treatable concomitant disorders for which screening tests are recommended. And for the pregnancy and contraception, women with SLE should be advised to delay pregnancy for at least 6 months after the disease has gone into remission, as SLE can increase the risk of miscarriage and worsening of the disease. The pharmacologic treatment for SLE are the following. We have the antimalarials. These medications are effective at preventing and treating lupus skin rashes, constitutional symptoms, arthralgia, and arthritis. They also help prevent flares. An example of this will be the hydroxychloroquine sulfate that inhibits chemotaxis of eosinophils and locomotion of neutrophils and impairs complement-dependent antigen and antibody reaction. For the NSAIDs, non-steroidal anti-inflammatory agents, this provides symptomatic relief for arthralgias, fever, headache, and mild sinusitis. NSAIDs may cause elevated creatinine or liver function test findings in patients with SLE. An example would be ibuprofen, naproxen, and diclofenac. TMARS, it is a disease-modifying anti-rheumatic drugs. It acts as an immunosuppressive and cytotoxic anti-inflammatory medication. This specific agent selection is generally indicated by the patient's organ involvement and disease severity. We have the cyclophosphamide, methotrexate, and azathioprine. For the cyclophosphamide, it is a reserve for severe organ-threatening diseases. And the methotrexate and azathioprine, it can be helpful for milder arthritis or skin diseases. Another example of the DMARS is the mycophenolate and IgIV. The mycophenolate is used for maintenance in lupus nephritis, while the IgIV is an intravenous immunoglobulin that is used for immunosuppression in serious SLE flares. Rheumatologics, belimumab. It inhibits the biologic activity of B lymphocyte stimulator. It is also a naturally occurring protein required for the survival and for the development of B lymphocyte cells into mature plasma B cells that produces antibody. Next, please. Corticosteroids. It is used predominantly for anti-inflammatory activity and as immunosuppressants. We have the methylprednisolone and prednisone. Other types of DMARDs include rituximab. Yun po. B-cell depletion with rituximab has been used successfully for rheumatoid arthritis. Next po. Unfortunately, Doc, we did not see any latest statistics here in the Philippines, plus lahat po, all of the documents that we see have payment. We get to request for the DOH po, but it takes months pa po, weeks and months before I can get the documents. So maybe I will just follow it up on another day.
Thank you for that, Mela. Yeah. So, okay, thank you so much. Okay, would you like to add some more, Joyce? Or you can continue now.
Ako, Doc, I would like to add something.
Okay.
This is a personal story.
Okay.
I had a classmate and a friend of mine way back in 2014. Our subject po then was the CPH, the Community Public Health. So we get to go outside, like just near our school, to do activities outside the school. And then siguro it's on our third week of the school na po when we notice that he has rashes all over his face and his arms. So at first we thought it was his bag because he just bought a new bag. But then the rashes did not go away, and then nagkakaroon na po siya ng mga headache, ganyan. And nagpa-check up po siya. And to our surprise, our friend got lupus po. So, kasabay ko po siya supposedly graduate in 2018, but since he had lupus, he needed to stop a few times. He almost did not graduate because he cannot finish his internship. He just graduated this last year yata, 2021 po. So he has he's been well na po right now. At first we thought the SLE will yung tatama po sa kidneys niya. But apparently, his kidneys were okay, but nagkaroon po siya ng complications sa kanyang hips. Nabulok po yung hips niya, so they need to replace it in 2020 po. Yun, so it's nakakalungkot lang po. But, yun po, may kambal din po siya. So, I told him to had his twin check, and okay naman po yung twin niya. Apparently, siya lang po yung may ganung sakit sa kanilang family. Yun po. And kasama po pala siya sa clinical trial. I forgot the hospital. I think it was St. Luke's or may clinical trial po na sinasagawa sa SLE patients, but he cannot disclose it to me due to the consent and legal forms. Yun po.
Okay, thank you for that, Jamela. Thanks for sharing. Okay, do you have some questions to the report of Jamela? Any questions or any insights you want to add some? Go ahead, Peter.
Good evening po. Ma'am Jem, just I have a question lang regarding SLE. SLE is somehow related with lupus anticoagulants. What's the possible symptoms if a person would develop those? Are there the possibility of bleeding, uncontrolled bleeding?
Yes, sir. It can cause blood clotting disorders lang po. I remember din po pala, in blood bank, whenever the lupus patients, they never get to be compatible with any blood. It has been in my experience that if the patient is hard to cross-match, it's usually very incompatible. Plus 4 po lagi ang grading. So, we knew that the diagnosis is SLE na po. Plus, ang pangit po ng blood typing. So, lahat po naapektuhan when it comes to lupus.
Then, Ma'am Jem, if that happened to a patient, let's say you have a suspected SLE, then incompatible for cross-match, what's the possible remedy, ma'am? Do you have an idea, or doctor?
Yes, sir. Our pathologists po, if they needed blood, they will just waive the type-specific blood po. That will be used for the patients. So far naman po, wala naman po nagiging reactions sa ward. But yun nga, pangit lang po yung results namin. But when the blood is transfused na, the doctor is closely monitoring the patient. No evidence of a fever, chills naman po. So, yun po.
Then, Ma'am Jem, last question. If a patient with SLE would undergo CBC, what's the possible result for his or her WBC count?
Leukopenia, sir.
Okay, so decrease. All right. Thank you, Ma'am Jem. Thank you, Ma'am Ibir.
Sir, additional din. Sorry.
Go ahead, Joyce.
For the prognosis po ng SLE, we have pre-prognostic factors in SLE that includes renal disease, hypertension, male sex, young age, older age at presentation, no socioeconomic status, being a black person, then presence of anti-phospholipid antibodies, the anti-phospholipid antibody syndrome, and high overall disease activity.
So if you have African descent, you have a low prognosis. Tama ba, Ma'am Ivir?
For prognostic factors.
Okay for prognosis. Okay, thank you po.
Okay. Thank you for that, Peter. And thank you also, Joyce. I have some clarification, Jem. So, based on the guidelines, yung recent guidelines that you shared earlier, so the titer that is considered significant is 1:80. Yun, ano? Or higher?
More than po. More than
Basta
what
more
is
than.
needed.
Pero let's say 1:40, so hindi siya significant. Dapat 1:80 or more.
Yes.
1:80 and more.
Okay, all right. Okay. Now, I just would like to add some more inputs. So, as mentioned by Gemela earlier, one of the ways to diagnose SLE is through ANA testing, no, anti-nuclear antibodies. So, there are different patterns that you can appreciate under the microscope. If you view it, no, meron yung homogeneous pattern, you have the speckled pattern, nucleolar pattern, no? So different patterns na makita ninyo, no, under the fluorescent microscope. Also note that not all patients positive to ANA are already diagnosed with ANA kasi some are drug induced. So there are certain drugs that might cause a false positive ANA. So kaya it is important that aside from the ANA, as mentioned earlier, the patient also undergo other testing like the anti-dsDNA, that's your double-stranded DNA. Gemela mentioned about anti-Smith, no? Why anti-Smith? Because this was the first person, no? The surname is Mr. Smith, no? The first person where these antibodies was recovered, hence it was named after him, no? Anti-Smith. And of course, one of the hallmarks of SLE is yung sinabi kanina is the hypocomplementemia. So you have very low levels of your complement 3 and sometimes low levels of your complement 4. No? And biopsy also is intended, no, for those with SLE. No, so there is this immunofluorescence testing also to look whether what is that type of disease, whether IgG, IgA, IgM, kappa, lambda. So they are also typed in the lab, as we all know. Okay, so thank you so much, Gemela. So at this time, I'd like to turn over the floor to Joyce to continue the report on SLE.
Doc, that's all po.
Oh,
I
okay.
compile everything.
You compile. So si
And
Gemela nag-present. Okay.
Yes po, Doc. I'll
alright.
report next in the finals po.
Okay, all right. Sige. Okay, so would you like to add some more or some insights, especially those who are working in immunology, serology, baka you're working on that lab, so you can share also your experience. Very interesting yung point kanina, no, regarding sa blood banking, no, where there is a problem in terms of screening, no, because of these auto antibodies. So it's difficult to type the patient, no. So the practice, I think in PGH is to use type-specific blood, no? Tama ba yun, Jamela?
Yes,
And then
sir.
probably you use wash.
Sometimes, sir, the blood type has problems din po. Usually, the forward typing is okay, but the reverse usually has the problem. So, they will not be compatible in any blood product, even the leukoreduced PAC RBC that we have. So our pathologists just inform the resident that since it's a difficult typing, if they needed the blood for emergency use, we can waive the blood with type specific.
Mm-hmm. And maybe wash RBCs, ano? wash pack RBCs, not hindi yung RBC alone. Just to
Yes,
remove
sir.
the
But
excess.
unfortunately, we don't do wash
Okay, all right.
RBC.
Okay. All right. Very good. Very good. Okay. Go ahead. I saw Kenneth ba yun? Sino nag-raise ng hand?
Doc, I have another question
Okay,
lang.
go ahead. Go
Okay,
ahead.
Ma'am Jem. Ma'am Jem, is it possible to transfuse irradiated blood for an SLE person?
Yes, sir. It's actually much better, but unfortunately din po. Wala po kaming pang irradiate. We usually recommend our patients to irradiate our blood units to kidney. Ano po yun?
Mhm.
Katabi po ng mga sakit.
NKTI. Yes.
Okay. So basically,
Opo,
ma'am,
NKTI.
nag-irradiate lang sa Philippines is NKTI? No other hospital? Or
Yes, sir. In my information po, we always recommend the NKTI.
okay, San Lazaro din. Okay. All right. Thank you.
Ma'am Sol, how much in San Lazaro?
Ma'am, sa ano po yan? St. Luke's.
Sorry.
Yeah. Yes. I'm not
Sorry
very
po.
familiar
How
with
much
the
po
price.
kaya?
Hindi
Do you
ko
have
lang-
any idea?
I'm not.
I'm not familiar po kasi nung nag-intern kasi ako doon, nag-irradiate kami pero yung price hindi po ako familiar.
Yes. Medical City. Medical City din? Okay. Alright. Ma'am Salom, so you're working in a blood bank, right? Tama? Blood banking?
Yes, Doc.
Oo. Alright. So, nagpa-process din kayo ng mga wash RBC?
Before, Doc, pero we stopped na po.
Okay. Yep. Okay, sige. Any other insights? I saw Kenneth. Kenneth, do you have some questions? Or you would like to add some more? Any additional inputs?
Ano question po?
No question, Kenneth? Yeah. Okay, may I invite the others, like, for example, can I call Yuzeng? Yuzeng, do you have some questions? Or Noor Usma? Sige, go ahead.
Yes po.
Do you have some questions or any insights that you'd like to add with regards to the topic on biomarkers and treatment for lupus?
None po.
None. Okay. How about, may I call Yun Yu or Ning Wang? Any additional inputs? Or do you have some questions? How about, how do you pronounce this? Chow Pian. Is that correct? I'm sorry. Pian Chow.
Yeah.
Yes. Do you have some questions to Joyce or Jamela? Is the
No.
report clear? Yeah.
No. It's
So-
clear.
Okay. So as I mentioned earlier, so they will be sending the slides, not in PDF, to me, and I will post that in the TLC so that you can have a soft copy of the reports. All right.
Okay, right.
All right. How about Alexander? You're quiet today.
Sir Peter already asked my question regarding
same question, pero-
Yeah.
Same question. All right.
Yeah.
Okay. So let me just ask again. So everybody has access to TLC now. You can access TLC. No more problems. Go ahead, Kirsten.
Doc, hindi pa rin po ako makapag-access sa TLC.
Not yet. Sige, I will take note. I sent an email sa TLC support. Okay, I will follow up yung sa'yo, Kirsten. So
Thank you, Doc.
aside from Kirsten, uh, Joyce. Same Joyce?
Same po, Doc. Can't
Oh,
access.
dalawa kayo? Okay, sige. But the rest are okay na? You're good na with your TLC? Okay. Alright, so let me just share again the slide early that I present. Oh, Gemella too. I can access na po. Alright, very good. So this is our schedule. So we're done now with the first report. This is on SLE, ano? So by next week, that's Feb 26, we'll be hearing from Peter, no, and Gabriela. They will be talking about this time on serum and tissue tumor markers. All right, so yeah, this is very interesting and important too, no? Serum and tissue tumor markers. Okay. All right. Okay, there's a question from Michaela. What is SAF? Okay, student assessment form, no? Okay. All right. Sige, try Joyce and Kirsten. Try the recommendation of Michaela, no? You need to send your SAF. Maybe they have to update something or upload. But I will follow up also. Okay. All right. So if there are no more questions, then we will meet next week and listen to the reports of Peter and Gabriela on serum